Yes.
I told you about it.
I'm sorry. Oh, it is 5 doors. It's the 5th floor. There's a last floor.
Not about like one in
Everybody has every.
we have someone that is from Mayo Clinic, Arizona.
Yeah.
He started.
Oh, okay.
He went with
But they don't have work in that. Yeah, that's right. They don't have trauma.
Southern California is before.
The craziest thing, they were like put up the air, and everyone else was doing it. They were just like,
Put it up there.
Blocking the low road.
but then when you look at the numbers of where probably doing about a third.
So there's 20 million people.
Yeah.
They have the California Kaiser.
Really around in the park.
Was just kind of like going purple and stuff like that. So yeah.
Is doing anything with the whole thing there? Fight with yeah, I know.
Gives me the stuff.
I know, now it's kind of
On call Anthony.
So actually, you know what? It's very similar, except you have better color in your face too.
I think it's good. It elevates everything.
We're bipolar. Of all the simulations ending at 10 p.m.
Whatever day.
You were supposedly supposed to be prepared. You actually don't think she's waiting. I've already even go up to 7 and they're operating. Communication,
I have it.
I think we're gonna get started soon. Good morning, everyone. Today we're gathered here for the Rudolph Lectureship. This lectureship is possible because of the generosity of Dr. Leslie Rudolph. For many of you guys, I don't know if you know, but all our Grand Rounds lectureships, they're supported by gifts from our previous faculty as well as grateful donors. It's their generosity that's played a big role in building the excellence of this department. So Dr. Rudolph, a little information about him. So he came to UVA Department of Surgery in 1963. He was recruited by Dr. Muller. He rose from assistant professor all the way to full professor, and he was heavily involved in building the emergency care system here at UVA, and also started the kidney transplant program. His work for research is well known in organ preservation, and that's been a lasting mark here. So even though he passed away in 1990, his influence is still felt here today. And today, our transplant program stands as one of the great strengths of our department. So today's lectureship is honoring not only Dr. Rudolph, but also those who helped shape the program. And alongside Dr. Rudolph, I also want to make sure we take a moment to remember a colleague, Dr. Avinash Agarwal. Some of you may remember him. Avi was a talented transplant surgeon, and from what I hear from all of his colleagues and staff, a very wonderful colleague. His sudden passing in 2022 was a big loss for the department, but his legacy continues in the work that we do. I remember very specifically, this was actually when I was interviewing here, I got a call from Dr. Reed Adams, who said, "Oh, you're going to be coming, but I want to let you know one of our surgeons just suddenly passed away." I was actually looking forward to seeing Avi. It's a small world. He was actually down the hall in college on my same floor. So I've known him for many, many years. It's interesting how small this world is, but it was a big loss for not only the department, but all of transplant. So with that, I want to invite Dr. Sean Pelletier to share more about Avi as well as introducing today's speaker.
Thank you, Alan. I just wanted to do a quick memory of Avi. He was a transplant surgeon here for 11 years. He grew up today's very much a New York day, so this is an honor of you, Ben. He grew up in New York, just outside of New York City. He attended Cornell as an undergrad, the Medical College of New York for his MD degree. He was at Indiana as a surgery resident. That was during the time where Indiana was one of the top 1 or 2 transplant centers as far as volume in the United States. He did his fellowship at Emory. Ken Brayman recruited him to the University of Virginia as a kidney surgeon in 2011, approximately 1 year before I came here. During that time, he ultimately rose to the level of being the program director for our fellowship. He also was the medical director of our organ procurement organization. For the transplant surgeons in the room, you'll be able to relate to this. During his 11 years, he did over 800 organ procurements. That's probably, you can multiply that by 8 for hours of work along with his daytime job. He was incredibly dedicated to the field of organ procurement and developing that, and really took our OPO from one of the worst in the country at risk of being decertified, similar to Miami, if you've been following the news, to being one that was really respectable. As Alan mentioned, these talks are really supported by our faculty sometimes in memory of our prior faculty. We do have efforts that are ongoing to continue to develop this, and this was really a moment for us to reinvigorate those efforts. I'd like to say one quick on Dr. Rudolph. He was at the Brigham for the first kidney transplant that was ever performed in a human. We are going on 60 years next year as being an active solid organ transplant surgery program, one of the older programs in the country. It's also a privilege today, in memory of Dr. Rudolph, to introduce Dr. Ben Samstein, a friend that I've known really going back to our fellowship days. He's currently a professor of surgery and serves as the chief of liver transplant and hepatobiliary surgery at New York Presbyterian and Cornell. He did his undergrad at Cornell, medical degree at Stony Brook, and then his fellowship at Columbia, where I've had several lifelong friends and have enjoyed kind of seeing our careers grow throughout the decade. Sorry, Ben. He also serves as the surgical director of the Living Donor Liver Program and is here today to share his pioneering work in minimally invasive robotic liver surgery, and specifically in the field of not only living donor hepatectomies, but also in the implant of the liver transplant. Something that people literally laughed at when it was discussed. So it's now a reality. Ben.
Well, thank you, and thank you to the faculty of UVA and their commitment to in visiting professorships. I can't describe enough how important they are for our entire surgical community. The visiting, the getting to know people, conversations and learning really begins around the ends of lectures rather than in the center of it. And so, last night, I got to meet faculty and trainees that, you don't get when you go through a Zoom. And I encourage you to make time all of you for in-person meetings, in-person visiting. There's so many experiences that I've had in my career of learning. I spent my first time I interviewed was either for Sean's job at the University of Michigan, which I didn't get, or I came down to UVA 10 years ago, interviewed for Sean's job, which I didn't get. And so anyway, I just encourage you to visit and learn, because relationships are kind of the critical aspect. All right, so I have no financial disclosures. I'm not doing robotic liver transplants because I'm not a consultant for Intuitive or anything else. Today, I'm going to be talking about the morbidity of liver transplant, the role of surgical complications in liver transplant, and how MIS surgery and liver transplant can potentially reduce those risks. So Jean Iman is my primary mentor. Jean started doing liver transplant in 1980 at the University of Chicago. So this was when they had cyclosporin, but they didn't have tacrolimus. And so everybody got a suprapubic cystostomy tube and a nasotracheal intubation and spent 2 weeks in the ICU. And there was a 50% morbidity. The average recovery took 3 months in the hospital and a year to recover. I mean, it was a terrible operation. And of course, we continue. I just want to mention, I recently went to a lecture from Sir Murray Brennan, and he was talking about the 3 phases of his academic career. The first was he wanted to prove that he could make a difference. Then he wanted to prove that what he had done was real. And then the last phase was I wanted to do less for the same result. And I know that as you go through your career, I see many people in the back that probably in the phase 1. I now know that I'm getting older because I'm definitely in phase 3 where I want to do less for the same result. So today we're going to be talking about MIS. So I don't know how, maybe through some collated paper, I came upon this article. And this was I do everything I can to avoid colon and anything inside the colon. I read this article about discharging patients within 24 hours after colectomy. And I thought, wow, that's really, why are we keeping people just to see if they have a bowel movement? So I said, well, what can we do this in liver? And I, as proof that I don't read much, it turned out there were many articles looking at, so I then, Googled, are there 24-hour hepatectomy? And there are lots of articles about short length of stay, obviously ERAS, but specifically the idea of could we do hepatectomies and keep people discharge them essentially the same day or the following morning. So we instituted a 24-hour hepatectomy protocol. And I promise I'll get to robotic liver transplants, but it was a little bit of a process before we started talking about it. So we decided who are we going to do 24-hour hepatectomies. So we do 24-hour hepatectomies if you're having less than two or less segments. So segments 2 and 3, segments 5, segment 5-6, segment 5-8, something like that. And then we have to educate the patients. We have to tell them you're going to go home the next morning before noon, 24-hour. Or some patients, they can even go home, if they're done early in the day, they can go home that night. They have to live close to the hospital within 90 minutes of the hospital so that they can come back. They have to have somebody in their family who speaks English, because about 50% of our patients, their primary language is English. So we started thinking, So that started us thinking it, we instituted it, we've been doing it successfully, and then we started thinking, could we possibly do a 24-hour stay after liver transplant? And my answer is no. And thank you all for inviting me. All right. All right. So we started thinking, what is the morbidity of a liver transplant? So delirium. A lot of our patients were dealing with delirium, renal dysfunction, hyperglycemia. Often our patients have to stay on an insulin drip for some period of time. Bile leak, bleeding, pain, rejection, and infections. And so we started thinking, how can we attack each one of these approaches? And we started with the easier things like delirium. But we also had to think about the surgical problems, the things that we were imminently able to control in the operating room, bile leak and bleeding. And so we wanted to think about how can we perform the operation with less complications. We started with delirium. So what we did was we reduced our intraoperative dose of steroids from 1,000 milligrams to 250. And we started giving all of our steroids in the morning because it was the nighttime dose that led people to have difficulty sleeping. And then difficulty sleeping with steroids led to steroid delirium. And so with that change, we went from delirium requiring medication from 20% to 2%. And so, if you're rounding on the, in the liver transplant service, and I round 18 weeks a year, a lot of delirium is exhausting for families. It's exhausting for providers, trying to reassure people that their husband, father's brain will recover after a liver transplant where they didn't expect delirium is a big deal. So this was very successful, and it started, I just put this slide in because I like one of the easiest ways in which we communicate to the ICU now is we have green track, yellow track, red track. We used to have A, 1A, 2A. It was like too confusing. So everybody understands green, yellow, red. Okay? Green means there's absolutely nothing, like this person should fly out of the ICU. They should, they barely need the ICU. They're often extubated either before they get to the ICU or almost immediately upon the ICU. You should get their A-lines out and you should just keep moving them. Yellow means like they're cold. And as soon as they're warm, you should keep moving them forward. And then red, liver transplant, oh shit. Everything, the liver isn't working, so, they're bleeding out of every line we put in and stuff like that. Don't extubate them, right away. All right. So I point that as a way of communicating across our teams that we found very helpful. So we started then focusing after the delirium and communicating across our teams on reducing surgical morbidity. And I had some experience that we did our first laparoscopic donor in 2008. And we adopted all of the left laterals, so segments 2 and 3 for pediatrics, were all done since 2008 using the laparoscopic technique. So I tried to convince colleagues throughout the United States that this was beneficial. We started doing full lobes in 2013. We did about, and I'll describe our experience. I tried to be controversial. I said, okay, even though nobody else is doing it in the United States, I think it's ready for widespread adoption, and presented it at the ASA, and that didn't change any minds, and nobody moved towards laparoscopy. And so there was a comment about data, and I thought it was, one of the things that I've come to find is that when we're presenting data, whether you're presenting 1% or 40%, when I was talking to people about the idea that we were going to do some of the donors laparoscopically. We were never able to achieve more than 50%. And so this references two psychologists who Daniel Kahneman won the Nobel Prize for their work on the certainty effect and understanding the emotional aspect of data. So we all think that we're rational human beings, and the reality is that we're not. We make almost all decisions are made because of emotion. So for example, we overweight outcomes with certainty enormously. If I tell people that if I tell them I'm going to increase you from 90% to 100% or 70% to 80%, people will almost always choose 90% to 100%. They love certainty. Even though as a percentage of increase, going from 70 to 80 is a bigger percentage, people don't like uncertainty. So really, all of this is a part of our process of how can we, so now we do all of our donors robotic. We have moved the needle from 40% to 100%. Now we don't have, I tell donors all the time, I'm not an insurance salesman. I'm not making guarantees. But when you tell somebody the last 3 years we've done all of our donors without conversions, they feel much more comfortable about what their expectations are than when you say there's a 50-50 chance. So worldwide, this is just more evidence that laparoscopy is laparoscopy is a tool, and that it's very hard to get complex operations to be done laparoscopically, whether it's laparoscopic Whipples or laparoscopic hepatectomies. That platform is very challenging for most people to adopt. So this is a paper of almost 2,400 hepatectomies, and basically showing that in Asia, where they were leading in live donor liver transplant, they were the main area that was doing pure lap donor hepatectomies. And so they would go and present mostly groups from Japan and Korea would present their experience, but their volumes were enormous, and they were also selecting cases. So if you're doing 400 live donors, you could select 30, and it would still be the biggest living donor program in the United States. So we decided we would adopt a programmatic approach to using the robotic platform as kind of laparoscopy 2.0. And so we were gonna, my partner Juan Roca came from Montefiore, and we were gonna even though I was a completely laparoscopic surgeon and had not done any robots, we were gonna adopt a programmatic approach to tackling everything together and with the robot. Okay, so we basically converted our entire practice from laparoscopy to robotics. This is a study we did of 353 hepatectomies, showing that we reduced our conversion rate, we reduced our length of stay. We've now done over 300 robotic hepatectomies, and all of our practice is moved to robotics. I'm not sure if this will play. All right, so this is our first robotic donor. So there, the platform, so that we, like everybody who does living donors, we do good mapping of all the vasculature, V5 and V8. This is a right lobe donor, and she was donating to her husband. I'm gonna kind of skip along the long video, but we do this completely the way that we do open surgery. So we take the short hepatic veins. We use a hanging liver maneuver where we get around the right hepatic vein with an umbilical tape. This is the inferior hepatic vein. which we take with a clip and a synchro seal to hang the liver. And then once we're that's the hepatocable ligament stapling, and then we get around the right hepatic vein. We place an umbilical tape around the right hepatic vein, and then begin our transection of the liver. The integration of ICG really makes a big difference. I mean, frankly, our cholangiograms are much better than what we used to do with what contrast enhanced cholangiography, where I would often have to incorporate in the cholangiogram and the thing that I was seeing in person in my brain, integrating them. And now it's all right on the screen. So this is the portal vein. And we are getting around the portal vein. That's the right portal vein there. And so we're around the right hepatic artery. We've color coded them. I always try to get the red one around the artery and the blue one around the vein. And then we Pringle. We now use a loop for Pringling when we need to Pringle, and do a ultrasound to look for B5 and B8, and then begin the transection. There's a lot of videos, so I'm going to move through this one. This is the longest. This is B5. And we do reconstruct all of our B5s and B8. We use CUSA, bedside CUSAing, for most of the cases for our donors, just to be as precise on the middle hepatic vein as we can. That's V8. And then this is the end of the transection. You can see the right hepatic artery and the right portal vein. The bile duct is cut. And we usually bring in a fresh scissors, gnaws away at the artery. And take it out through a fat and steel extraction. All right. So prior to during the earlier era, when we were doing laparoscopy, we were doing a lot more left lobes. The reality is that most of our recipients needed right lobes, and so you can see in the robotic, we went back to kind of the way we were hybrid is basically open. It's midline, upper midline incision. And so we were at 88% robotic, right lobes. And when we switched to robotics, we went back to all of our, 90% of our cases being right lobes. And then I just want to point out, so we definitely had a learning curve. We had a couple of cases early on in the first 10 cases where we had 2 bile leaks, and we had a patient who needed to go back to the OR for bleeding. So a donor. And so that was part of our learning curve, but much shorter than we did in laparoscopy. So era 1 was in our donors at Cornell. Our first 60 was cases, era 1, and then era 2 was when we adopted the robot. So we now do all of our grafts, complex grafts over 1,000 grams, 2 portal veins, 2 arteries, multiple hepatic veins, and 2 bile ducts. So I think this is a video of so this is a 1,600 gram right lobe, which is a pretty big right lobe graft. In fact, it wouldn't fit in our normal EndoCatch bag, so we had to bring in this heavier bag so that we could get it out without tearing the bag. Because one of the things that's always very uncomfortable during a live donor liver transplant is when the liver's swimming somewhere in the abdomen in a bag that's ripped, and you're like, I can't get it out. So, all right. So, now we've done 27 donors, actually 30. This was at 28. We had one case that we aborted due to the recipient had a PE during the case. And as I showed, a lot of complex graphs. And our ABL is low. We send them all to the ICU for one day. But the donor operation takes a long time. We have one other thing I'll just mention that we have done based off of this trial. We instituted a 3-day low kilocalorie liquid diet for all of our donors, which definitely does cause the liver to be smaller and less bleeding. We Pringle about 50% of the time, where we used to do almost 100% of the time Pringle. All right, so with that, less blood loss. And so we started thinking, well, my partner, Dr. Roca, said, well, if we can do all the donors robotically, could we start thinking about the recipients? And so this is actually our first recipient. This was a deceased donor liver transplant, but we weren't the only ones. Throughout the United States and the world, there have been people thinking about doing liver transplants using an MIS technique. There were people who were doing it in Asia. It's been reported doing laparoscopic, and then a number of people in Portugal, in Saudi Arabia, and in India doing robotic liver transplants. So the Saudi criteria, so this is out of Riyadh. This is the largest center doing robotic liver transplants. So not low meld, but lower meld, melds under 30, where they have space. They prefer patients who've had ascites, no previous major open surgery, so like nobody who's had a previous hepatectomy, no significant portal vein, single artery, and then the number of hepatic vein reconstructions is expected to be less than 2. They have now done over 100 cases. And what they have found in their experience is that they actually are having less complications, less bile leaks, and less bleeding. Now, their patients are selected for less complex anatomy, so there's definitely a bias. But living donor liver transplant has been associated in the recipients in the A2ALL study. So this was a consortium of about 9 centers throughout the United States. The bile leak rate is somewhere around, biliary complication rate was 35 to 40%. So a very, very high rate of biliary complications, and I'll show you our experience. So we started with doing the tectomy robotically. So we did all of our operations together in the beginning. So Dr. Roca and myself, so we only had one robot surgeon at a time. And so in the beginning, we would do laparoscopic donors, and then we would do the hepatectomy for the recipient robotically. And this is the graph going in, and you can see we used an upper midline. So we did the native hepatectomy robotically, and then made an upper midline and put the graft in and did the transplant, what I would call an open technique. And so we did 3 of those, where a planned laparoscopic donor and a open implantation. We then went on to attempt robotic DDLT. So implant the donor, the deceased donor graft robotically. And we felt comfortable. So in terms of doing the native hepatectomy, the bleeding was modest. We were able to get the livers out, but the liver's a slippery beast. Lining up the cava for our cavostomy, getting the liver to sit right was very, very difficult. And we actually converted all 3 for implantation. So we had done the hepatectomy, but we did not succeed in the implantation of a deceased donor. We also had to be very thoughtful. We were talking about yesterday about looking at donors' head CTs for DCDs. We started thinking, okay, well, we really have to find grafts that are quite small so that we can fit them in the abdomen under basically laparoscopy. So the next stage was we were able to succeed. We used a hand port in which, so this is a deceased donor liver. We do a cavo-cavostomy. So you can see there, we are sewing in the graft. This is a deceased donor graft. And so we prepared the cava, that's the portal vein there. And that's the hepatic artery. And that's after the hepatic artery, and this is the bile duct. We were able to do 2 deceased donor liver transplants robotically, both low MELD patients, relatively what we would call low MELD. MELDs were in the teens, but I hope, my point here is these patients did have cirrhosis and portal hypertension. You can see there a recannulized umbilical vein. This isn't like cherry picking. We cherry picked, but we cherry picked in a specific direction. Okay, so we didn't. You can see. I mean, what I think you can see there is that the patient has a lot of abdominal domain, right? He had a lot of ascites. There's a lot of space from the laparoscopy, so we had space to work with a full organ graft. So then we started doing our robotic living donors. So we have a pretty robust living donor program. We're on pace for about 20 living donors this year, and we started in May doing robotic live donor liver transplant. We do the donors robotically, and we do using a separate team, we do the recipients. So the portal vein is harder. The portal vein is harder because the portal vein is very, very short, and I'll tell you, and then getting the graft is very time consuming. The artery is easier because of the magnification. The bile duct is difficult. It also turns out that the clamps that we were using on the cava don't always fit for coming out. So we once we've sewn the portal vein in, the clamp is on the cava is kind of stuck, and so we're redesigning the clamps. So this is part of the learning curve of robotic liver transplant, is that that liver transplant clamps were designed for big open surgery. And so the problem with the clamps is that the handle hits the abdominal wall. And the abdominal wall can only be moved so far before, if you're going to stay laparoscopic. I mean, you can open the abdominal wall to get the clamp out, but undermine your whole effort. So we've now done 8 total robotic liver transplants. And then we run with 2 simultaneous robotic teams. And I think this is the implantation of a living donor graft. And you can see that's the hepatic vein. And that is a relatively straightforward anastomosis. The portal vein, so what we've done, let me just pause this for a second. So we take the portal vein from the recipient, and on the back table now, the last 2 cases, we sew it onto the graft to give us more length, to make the portal vein anastomosis easier. Because if the portal vein is very, very short, robotically, there's just a lot of movement of the organ is very, very difficult to deal with. So, so that's how we deal with the harder portal vein. And then let me go to the artery. And the artery, because of the magnification, is really easier than open. That's the artery anastomosis, and then the bile duct. And at the end. So, a little bit of tissue and snow. All the things that liver surgeons like to in our religion. And then I think I have, that's the same video. Okay, so this is our summary of all of our robotic cases. And so we've done now, as I mentioned, 8 cases. Looking at our experience, so you can see, they're not all one group, they're not all PSC, they're hepatitis B, NASH. We did a Caroli's with cholangitis, colorectal mets, alcohol. All of our MELDs are median MELDs. So what I would call median MELD between 13 and 19. So nobody with a MELD score of 6, but nobody with a MELD score of 30, no portal veins, and Phanestoel insertion sites. And the last 3, no complications. We started using pancreatic stents in our bile ducts. It's a short 5 French pancreatic stent. And our length of stay for our recipients, I know you guys have a very, very short length of stay, but our median length of stay is about 8 or 9 days. Now in our live donors, the last few cases, it is 8 days. So that is my talk. I think what I believe, and I told Alan and Sean that this is going to be a bit of a belief talk because 8 cases is hard to prove to you anything. That liver transplant is a highly morbid procedure with a long length of stay and a high incidence of complications. I think the robotic platform, what I call laparoscopy 2.0, and with the new DV5 and haptic feedbacks and some of the other information that we're going to get, it's 2.1, enables an MIS approach to liver surgery and liver transplant. So we now plan half of all of our recipients for our LDs. All the donors are done robotically, but half of the recipients we plan to do. As I said, it's all about framing. 50% still isn't enough. We got to get to, near certainty, so that patients can understand that when they come, they'll be having an MIS surgery as our default rather than picking and choosing. But a multimodality approach to reducing medical and surgical complications doesn't get us all the way to 24-hour liver transplants. But if we can get people recovered in 4 to 6 weeks after a liver transplant, because they're surgical, because they haven't had a bile leak and they have no hernia, I think that liver transplant becomes a much more viable therapy for a lot more people. So, thank you. This is my team, Dr. Roca, Dr. Liu, our PA, and our fellow. And I'll just mention that we are looking for someone who's interested in research to come to New York City. We just secured funding. If anybody knows surgery residents throughout the United States who want to come and get involved in robotic surgery and research related to the outcomes, please come to New York. And we can, this is our softball team playing we're all dressed in red. We play against Columbia, all dressed in blue, once a year in Central Park. Thank you.
Thank you. And it's really amazing pioneering work. As I said, we talked about this 10 years ago, and literally everyone said this will never happen. So it's happening. It's really amazing. I've always kind of, as the 4th year surgery residents and the fellows come on our service, I tell them transplant is just like general surgery, except it's completely different. And what I mean by that is, we talked about this a little bit, we feel the most comfortable taking care of the sickest, operating on the sickest patient in the hospital. And we're scared out of our minds of taking a completely healthy person to the operating room to do the living donor hepatectomy. So how did you overcome those kind of barriers, in both from the sense, New York City is well known for, a index case of a donor mortality that almost stopped living donor liver transplant in the United States. How do you overcome those barriers, both personal, professional, and national?
Yeah, so thank you. So I'll just tell you, liver surgeries, I'm going to tell a little story. So liver surgery is a very international field, and so it's very satisfying in some ways. So I went to the first international laparoscopic liver surgery meeting that was held in Paris in 2017, and I was walking along the Seine with two other live donor liver surgeons, and in the summer, quite nice. But each of us had a story of a donor who had had open surgery and had had devastating complications. So for me, it was a young woman who had donated to her sister, and she developed a small bowel obstruction and had chronic abdominal pain and developed, this was 2013, developed an addiction to opioids. And, basically mom would come to me and say, the recipient had Hep C. This was prior, I think the transplant was in 2010, before Hep C drugs. And so the sister, who was 30, had recurrent Hep C and was dying. And then the mother of the other woman, so she came to me and she said, both of my children are destroyed, one with opioids and one with recurrent Hep C. You must help them. You must help my daughter who has the recurrent bowel obstructions. And it was, someone with recurrent bowel obstructions and, an addiction disorder, it's a devastating disease. And it was, nothing I could do. And as I walk along, David Kwan, who's a surgeon now at USC, who was at, came from Samstein in Seoul, had a similar story of a woman in Korea who had donated to her father and had recurrent pains and, had committed suicide years later after her donation. And then a surgeon from India had a similar story. And each of us who were doing laparoscopic donors were driven to change because the consequences for young people of surgical morbidity was significant. So that's part of what drove me, was seeing patients who I felt had been injured by their donors. So I guess I could have stopped and not done donors at all. But my approach was, is there a better technique? Is there a way? Our hernia and SBO rate has gone to essentially zero. We had in our open midline, we had 15 to 20% hernia rates, even in young, low BMI patients. We had a lot of hernias, and we had SBOs. So that's part of what drove me.
Charlie.
Yeah, I've been through this with colon surgery, going from open to laparoscopy to robotic, so I understand sometimes the pain too that goes associated with it. You can do something really well one way, but my question to you, and maybe you talked about it, maybe I'm right here, but there's got to be an extraction site. So Kevin talked, and the liver is a big organ, right? So how big are your extraction sites? Where do you make your extraction sites? You say you have no hernias. Sometimes you get, so how you minimizing that by choosing your extraction site?
So we make a horizontal fan and steel incision, and we make generally a 12 centimeter fan and steel incision. I like to say that, I'm not trying to be the most minimally invasive cannon steel liver transplant surgeon. Like, couldn't we, this is a smaller graft, couldn't we make it 10 centimeters? Oh, this is small enough. We're doing this.
You don't want to damage it, because I've done
Right.
that. I've pulled colons out and then ripped them, and then all of a sudden I get a. bad
You
infection.
don't want to damage the organ, both taking it out or putting it in. So, we use for left laterals 8 centimeters, for left lobes 10 centimeters, and right lobes 12 centimeters. That's how we get them in and out. It definitely positioning the graft, because you have to line the cava up perfectly. To clamp. It can take 10 to 15 minutes of warm time to line the cava up. And at a time when we were doing open implantations with like 35 to 40 minutes, we've definitely gone over 60 minutes with our implantations, which, is stressful.
This is, oh, please, Cisco.
Thanks, Ben. Are there any donors that you would consider, okay to be an open donor instead of a robotic donor?
The short answer is no. If we have multiple portal veins, we'll just take each separately and then reconstruct. It's hard for me to envision what is the donor that is so complex that
Still a candidate?
yeah, it's still a candidate, but I won't do robotically. I mean, I think that, someone who has innumerable hepatic vein reconstructions, I'm more worried about just outflow problems in the recipients. But most of it is manageable robotically.
So on the robotic implants, you didn't really show the outflow reconstruction. Are you doing a jump graft to the right hepatic vein and doing one anastomosis, or are you doing multiple?
We do a single outflow. So the middle hepatic vein and the right hepatic vein are combined into a single. So it's a single cavo-cavostomy. So there are cases we're still selecting where we won't do the implant robotically because of the complexity of the implantation. So for example, a V6 that's very far away, we'll rather take iliac vein and make a single cavo-cavostomy, because sometimes the inferior hepatic vein can be very, very large and needs to be reimplanted. So, and it's very far away from the right hepatic vein.
So any other questions? So as a small thank you for your visit, we have a small traditional gift that we give to everyone who visits UVA. Thank you. Thank you very much. That was a great talk. Francisco's going to be at the robot if you're looking for him today. He's going to be practicing. Get ready.
See you about like 9:30.
Yeah, okay. Perfect. Yeah, I don't know yours yet. You should.
I think we need to get out of it. Talk to him about it. We do it now, we probably would need an ostomy and he's like,
Very surgical, not a lot of data, but
Yeah.
Yeah.